an overview. So the idea is that I would like to give you a little bit of overview about who we are and what we do in the HoliCare consortium. And then the other presenters will be focusing on the lower tract infection as the topic is for today. Who we are, it's a very long title, and that's why I only are going to be saying HoliCare, but it stands for a holistic approach in patient management and epidemic surveillance through convergence of diagnostic technologies, capacity building, and stakeholder engagement. In a nutshell, the ambition of the HoliCare is really to bridge the gap between technological advances, infrastructure, capacity building, in order to uptake these new technologies locally. And we have focused on a very important disease, basically on respiratory tract infections in low and middle income countries. Throughout this presentation, I'm going to be referring to the 4 parallel pillars, which really makes the core of our project. So we have pillar A, B, C, and D. I will get back to those, and hence the title HoliCare, because we're looking at it from a holistic point of view. So who we are a consortium consisting of 14 partners, and out of those 14 partners, we are fortunate enough to have 4 sub-Saharan African members from 3 different countries. We have from Ethiopia, Senegal, and Uganda. It's a 3-year project, and it's been financed by the European Commission. In this particular finance, it comes from this innovative approaches for enhanced poverty-related diseases in sub-Saharan Africa. And HoliCare is one of 6 successfully funded consortium within this call. And this particular call fits into a larger area when it comes to the health. As you can see here, we are basically getting the money for this infectious disease, including poverty-related neglected diseases, a part of the focus. So very briefly, infectious diseases, I guess most of you might have seen this picture. This was a review from 2014, illustrating that by the year 2050, antimicrobial resistant related mortality is going to be surpassing cancer and will be the #1 mortality globally. So why are we focusing on resource limiting settings? This particular picture that I'm showing here shows all the hazards that were reported between 2001 to 2013 to WHO. Infectious diseases sticks out. It stands for about 84% of the reported hazards, and it's quite high concentration in low resource settings. And hence has been really the focus of the HoliCare project. And within that, as I was saying earlier, we've really focused on lower respiratory tract infections because it's a really global threat. And we will be able to present this more in detail in the coming presentations. But it's one of the major poverty-related diseases, representing about 40% of death and 17% of cases reported in sub-Saharan Africa. So the project really is relating to this one, and it also connects very well with the EDCP, which is actually the European and Development Countries Clinical Trial Partnership in focusing on sub-Saharan Africa. From a technology point of view, we normally talk about point-of-care diagnostics. Point-of-care diagnostics is a test that could be done near or at the patient. So really at the point of where the patient is, It allows you a number of, it has a number of benefits, including it's convenient, rapid, high quality, and portable. So from a definition point of view, this is a test that could be done by anyone, anywhere, at any time. And when you look at it from a resource limiting settings, we often talk about a criteria that needs to be fulfilled. This is the assured criteria, and assured stands for affordable, sensitive, specific, user-friendly, rapid, robust, equipment-free, and deliverable. This is a kind of, let's say, a shopping list for technology providers in order for a technology to really be applicable at resource limiting settings. And very recent, this was updated where two words was added. This is RE. Basically, R stands for real-time connectivity. E stands for ease of specimen collection. And really, the HoliCare consortium is adapting this within our way of thinking when we are developing diagnostics that are then to be used at resource limiting settings. So the overall picture is, how can you improve disease management diagnostics in rural area or technologically underdeveloped geographical locations? And more specifically, HoliCare is about the development and decentralization of point of care technologies, where we combine this with capacity building, training, and implementation towards improve overall healthcare of delivery of the healthcare in sub-Saharan Africa. So the holistic approach I've been talking about is that we do it by developing innovative diagnostics, combine this with capacity building, including human capacity, focus on sustainable training and adaptation in terms of looking for business model and systems that could be adapted for lower to middle income countries. So this is a little bit busy picture, but what I'm showing here is that we have successfully been able to identify the stakeholder. The main stakeholders here are basically the universities, biobanking, hospital, local clinics, remote areas. And together, the idea is to have a patient-centered delivery where you do testing to treatment, healthcare system integrated with low cost, sustainable training, capacity building. So we have two parallel technical diagnostics. One is what we call multilateral flow assays, which is basically a lateral flow assay that could be done at the field for screening, and then you can, based on that, refer to a hospital. The other one is advanced molecular tool based on an isothermal amplification method called LAMP, combined with host response biomarkers, looking for immunoassays to look for host response to infections. And both of them combined with a hardware that is then being able to connect to a database for ease of data handling and also connecting with hospitals. So the objectives, we have clearly defined objectives, the 8 of them addressing in the HoliCare. So bear with me. The number 1 is multi-level lower tract infection disease through 3 systems. One is the screening method based on lateral flow assay. The other one is molecular tool looking for based on an isothermal PCR based on LAMP. And the third one is host response based on immunoassays. The second objectives is digitalization of the healthcare delivery, basically mobile connectivity, connect this into a cloud-based solution. The third one, medium-scale clinical trial diagnostics. This will be performed both for the lateral flow assay as well as the point of care instrument for the molecular and immunoassay. The fourth objective is disease diagnostic supply enhancement. Again, through training and also looking into identify stakeholders and impacting how investors can be coupled to us. So this fifth objective is to develop a lower middle income country-based business model that could make this into a viable way forward post the HoliCare project. The sixth is network access to diagnostic results data. 7, project engagement with other activities within the EDCTP network. And the 8th and last is development strategies to bridging the gap between research labs, field deploying through training and implementation. So all those projects in a nutshell are delivering a focus on poverty related diseases in sub-Saharan Africa, combining health technology with other scientific areas, medium-scale clinical trials and clinical research studies, increased collaboration with investors, developing cooperation with international partnership, implement pharmaceutical companies, involving pharmaceutical companies and other SMEs, solution integrated with existing digital patient data management system, including also promote collaboration with other funded projects by sharing project relevant information, etc., in order to maximize the outcome of the other parallel programs. The last one is to promote integrated research in healthcare and system delivery on a daily basis. So which means all of those objectives are part of our 4-pillar parallel activities. I'm running out a little bit of time, so I'll go a bit faster on this one, but in any way, Pillar A deals with the technology part, Pillar B, capacity building, Pillar C, training, Pillar C is adoption, and then Pillar D is training. And today's activity is part of this Pillar D, training. So we have 10 work packages accompanying all the pillars. The color code here is basically all the pillars that we have within this different work packages. They are interconnected and organized in a way that we basically have synergies between each of the pillars. So again, I'm coordinated together with Ines Pinto from our group here. We have a research office that supports us, and technical coordinator is then Professor Zulf from Teeside University. We have a management team, and each of the members of this consortium has a certain area of responsibility and area of expertise. So summary, HoliCare is all about a holistic approach supporting the massive uptake of innovative diagnostic technologies. As part of this, today's activity deals with HoliCare Academy, which is really designed to reinforce human capacity building in sub-Saharan Africa through a number of different activities. And is it one word I would like to leave you with? It's that alone we are excellent, together we're brilliant. So we are really fortunate and happy to collaborate in order to address poverty-related diseases. With that, I give you back the floor, Jean-Claude.
Thank you. Thank you very much, Amman, for your great presentation and taking us through the HoliCare project and what we do in particular. Yeah, you just use your time efficiently. You have 2 minutes, and we also have our 5 minutes question and answers. If there is any comments about this presentation, we can just have 2 or 3 questions or reflections before we welcome the second presenter. So if there's any comment or reflection, you just raise your hand and then we can give you the floor. Otherwise, we can get prepared. I think the next presenter will be Professor Tobias, who will take us through some global perspectives of respiratory tract infections. So I think I'm still looking for the presenters. Still, there's no comment. But we have also a wrap-up Q&A session. So if there is any popping up like reflection or comment about our project, each audience member is more than welcome. So as we don't have any raised hand so far, may I just welcome Professor Tobias to continue straight ahead with his presentation. Thank you very much.
Thank you so much, Jean-Claude, and thanks so much, Amman, for that introduction to HoliCare. And it's always nice to see what we aim to do together and what we have started together. And I always get a bit impressed about what we're actually trying to achieve together. I hope that you can see my slides, because now I have been asked to give a short introduction called The Global Perspective of Respiratory Tract Infections. And I will give a global overview, and then we will zoom in into particular countries and particular issues. But before we do that, I think it's always nice to warm up with a couple of quick questions. So please bring up your phone and be ready for a couple of quick questions. I hope that you can see my screen and that you're now watching the Kahoot screen. So either you can just take the QR code or the game pin is 161189. And please go to kahoot.it, enter the pin code, or just take the full phone and get the QR code. That's the quickest one. I have M, Put, Ahmad, and P. Please, a couple of more and we will get ready. If any questions, please write in the chat, and Jean-Claude and I and Putumani will together help you. And if you're sitting together, you can do this as a teamwork. As Amman said, alone we're brilliant, but together, no, alone we are excellent, but together we are brilliant. So it looks like we have 15, soon 20 participants. Let's get started. You can always join. You will have the QR code and the game pin up there. Are you ready? Let's go. So respiratory tract infections. The first question is the following one. One of these is a respiratory tract infection: pneumonia, asthma, chronic obstructive pulmonary disease, COPD, or meningitis. One of these is a respiratory tract infection. You need to be quicker. You just have 5 seconds to go. Quickly. Wow. Very good. The combined knowledge, pneumonia. That's the one who is a respiratory tract infection. Asthma, that's not an infection, might be exaggerated by an infection. Chronic obstructive pulmonary disease, mostly smoking, also can be worse by an infection. And meningitis, that's in the brain. We will continue. Good. And Min, Ahmad, and Joe, you're quick and you're right. Second question out of 6. Lower respiratory tract infections are the leading cause of death in the world, in Asia, among all infectious diseases, or in Africa. And now it's very nice. We actually got the response already from Amman. So if you listen to him, you have the right answer. You are more? A couple of questions, please go. Lovely. It's not the leading cause of death in the world, but among all infectious diseases, it's the most important one. Very good. Ahmad, Min, and EFM. Very good. Let's go. Now, it's just true or false. If the cause of upper respiratory infections is unknown in children under 5, evidence supports antibiotic use to prevent complications. So in children, if it's an upper respiratory tract infection that I have now, a cold, is it good to always give antibiotics or no? We almost got the response from Amman as well. You have a couple of seconds to go. Please, 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 please. Very good. It's false. For a common cold, antibiotics, it's never needed, and it should not be given all the time to prevent complications. If it's a lower respiratory tract infection, it's different depending on the setting, but here you don't need antibiotics. Sometimes you need to follow up. Well done. We continue. Ahmad Min EFM, quick and right. Now, fourth question, respiratory tract infections, seasonal variation. They always peak in winter for all causes, most peak in winter, but some during other seasons. Couple of seconds to go, now you're quicker, and that's very, very good. Lovely, go for it. Lovely. So most peak in winter, especially in the Northern Hemisphere, but not always. And now since the pandemic, it's really varying. Great. Combined knowledge, you're very good. Ahmad, Min, and EFM. And Ahmad, you see, on fire. Second last question. Deaths from respiratory tract infections only occur in children and the elderly. Only in children and the elderly. Now, you're very quick. Impressed. That's great. Can be even quicker. Quick. A couple of you left. Good. And we have a slide here to show this. You can see this is mortality from lower respiratory tract infections by age group, very much in the young children and a lot in the elderly. But we have mortality all over the age groups. On the x-axis here, this is age 1 to 4, 5 to 9, etc., etc. Most pronounced in the children and in the elderly, but it's an issue for everyone. Lovely. Let's have a quick look. Number 3, Min, congratulations, and applaud to Min. Number 2, to EFM, an applaud. And who is the winner? Number 1 on the podium, Ahmad. A big applause to everybody. Well done. And then Chris and Put, you were close. Thanks a lot for participating. Bring these questions with you to the next slides. Great. So now we start with some definitions. Just when we discussed, and you heard, a concept that we use a lot in global health and in public health. This is DALY. And DALY, that means disability adjusted life years. And this is a way to measure how disease and medical conditions affect the length and the quality of life for a population. So it's not only death, you also include morbidity when you get ill, but you don't die. Otherwise, as we saw during the pandemic, the COVID-19 pandemic, we almost only focused on the dead. And there you count a 95-year-old as much as someone who's 20. When you use the concept of DALY, someone who dies young is counted as a bigger loss of DALY than someone who's old. And also morbidity when you're ill is counted. So the summary, the sum of years of life lost due to premature death and the years lived with the disability due to disease or health condition in a population. That's DALYs instead of just calculating deaths. And here we have a schematic view, and the upper respiratory tract, that's the nasal cavity, the pharynx, and the larynx. Once it's below the larynx, you get down in the trachea, the primary bronchi, and the lungs. Down here, it's the lower respiratory tract. Down here, it's the lower respiratory tract infections. And up here, you have a normal cold. Down here, pneumonia, often RSV infections, which they are more severe. URTIs, upper respiratory tract infections, the common cold, lower respiratory tract infections, pneumonia, bronchiolitis, and others. So now let's move on and look at the global burden of respiratory tract infections. Then if we start looking at it globally, I hope you can follow my slides here. Then you see in 1990, respiratory tract infections and tuberculosis was #1 of all causes of loss of DALYs. 2019, this has changed a lot. Now we have cardiovascular disease #1, neoplasm, meaning cancer, maternal neonatal morbidity and mortality, other non-communicable diseases, and then we have respiratory tract infections and TB. As #5 globally, still high up, but not #1. However, again, as Amman said, if we look at low-income countries, we see that there are infectious diseases as #1. And it starts with diarrhea, lower respiratory tract infections, malaria. So all these three infectious diseases in lower income settings, and lower respiratory tract infections as #2, and very close between lower respiratory tract infections and diarrhea. And if we look at it, the global burden of disease, lower versus upper respiratory tract infections. So here it's very important. On the x-axis, this is from 1990 to 2020. And on the y-axis, the scale is not the same. So this is for upper respiratory tract infections, and it's up to a maximum of 4 million DALYs lost. When looking at lower respiratory tract infections, it's 150. So it's very important, much more with lower respiratory tract infections. Upper respiratory tract infections, as the cold I'm having today, it's annoying. It's not something you want to have, but very low mortality, hardly anyone, and the morbidity is also little. Lower respiratory tract infections, a big difference. Upper respiratory tract infections has not changed a lot. Asia, Africa, America and Europe, more or less the same since the 90s. We all have colds. We know, every one of us who has children, winter times in the northern hemisphere, they're having cold all the time. If we look at lower respiratory tract infections, has been decreasing for both Asia, and a massive decrease, and sub-Saharan Africa, although the decrease is not as big. And in Asia, we know that there has been a massive improvement in social conditions. So the social determinants of health, they have improved so much compared to in sub-Saharan Africa. That's the biggest reason for this. Less malnutrition, better education, better water and sanitation, and also better healthcare system. Easier access to antibiotics when needed, easier access to oxygen when needed. But you see, it's moving in the right direction. Also for sub-Saharan Africa, although much slower. So we're aiming in HoliCare, now the project, to get the same slope in sub-Saharan Africa as this one, up, down. So what have they been doing right? A lot, although they have quite some way to go. So if we look at it by region and age, and we start looking at it by region. So here in the dark red, you see this is upper respiratory tract infections, very little. The bright red, that's lower respiratory tract infections, much more. And here's Africa, and here's Asia, America, and Europe. So it's in Africa and Asia where we have the problem. And that's why it's so good that we have focused on working together between the EU and sub-Saharan Africa, where we have the global burden of lower respiratory tract infections in the world, and this curve that is not moving as fast in the right direction. And now this scale is different than the one we had before. Now we have from just 0 to 6 days, 7 to 27 days, and then 28 to 364 days. So we see it from birth until the age of 5, we have a massive here burden of disease due to respiratory tract infections in the children below the age of 5. And this is a mix of pneumonia due to bacteria and RSV due to viruses and other viruses, and we get to know more and more. Then we don't have that much, but still we have a burden of disease here also in all ages, and then it's increasing again in the elderly. So upper respiratory tract infections, normal colds, often self-limiting and non-fatal. We have $6 million lost in 2019. It's low all over. And the incidence is even higher in high-income countries sometimes, but often it's the same. Often we get a cold, we get tired, it's a bit difficult, lowered productivity, lower quality of life, but not for long and not that bad. Most common etiology is viral, almost always viral. Sometimes you can get the bacterial colonization, but it's very rare. And most of the times you don't need antibiotics. And here it's great to see 20 years ago, when I started working as a pediatrician, I very often got the question from parents when they were seeking care from what I saw as a normal cold. Oh, couldn't we get antibiotics? Can we get antibiotics? I never get that question any longer. Often, when I prescribe antibiotics, I get it the other way around. Is it really needed to have antibiotics this time? And you can prescribe and say, I believe this pneumonia, lower respiratory tract infection, is not bacterial. We can wait a day with antibiotics, and they agree. So they have understood it's not good for the individual patients, and it's not good for the society with overprescription of antibiotics, again, as Amman showed. So it's possible to target the prescribing and dispensing of antibiotics for upper respiratory tract infections to avert antimicrobial resistance. Although it's not something you get for free, and it's a big difference in the usage of antibiotics in different countries. Comparing just Sweden and France, twice as much antibiotics per person in France compared to Sweden, and if you compare France and Spain, again twice as much. And we don't have a difference in the incidence of infections. Lower respiratory tract infections can be either viral or bacterial, or even sometimes fungi. The leading etiology is pneumococci pneumonia, so that's bacteria, and here you need antibiotics. But very often it can also be viruses, and more now, since we started with vaccinations against pneumococcal pneumonia, some of the strains, not all of them, we have seen a lowered incidence and more viral. So here it's very important that we get better at the differential diagnostics between viral and bacterial. And again, the leading cause undernutrition for children with a bad nutrition, and also elderly which are malnourished. Big number of DALIs lost. Here we need vaccinations, integrated management of childhood illnesses to reach the children, and better diagnostics. So if we look at the children, this pie chart is for children below the age of 5, and the yellow here is the neonatal period. And in the neonatal period, it's mostly birth asphyxia as the leading cause of death, and not getting enough oxygen at birth. Neonatal sepsis, it's an infection, but it's not pneumonia, and being born too early, prematurity. But also pneumonia, even in the first 28 days of life, is an important cause of death. And if we then survive the first 28 days and get to the post-neonatal period, 1 to 59 months, the biggest cause of death in children is pneumonia, and 13% of all children, the 5 million children that die every year, is due to pneumonia. So more than 600,000 children below the age of 5, they die every year. And here, it's important that we find the right balance. When antibiotics are needed, they should get antibiotics as quick and efficient as possible. When not needed, they should not have antibiotics. It's not good for the children, and it's not good for the society. So, again, the global burden of disease in 2019, lower respiratory tract infections is the second cause of loss of DALI combining morbidity and mortality. And that's why we have HoliCare. We want to find a solution here. That's why we have the holistic approach. It's not enough just to develop new diagnostics. It's not enough just to build capacity. It's not just enough to raise human capital. And it's not enough with innovation. We need to work together. Combining this and everybody working together in this fantastic team. And this presentation, I would like to thank Putumani Mnotshva so much for making this with me, and then Julia Gaudenzi, also part of the team here from Karolinska, and the whole HoliCare team working together to deliver on this. So again, let's continue the work together. As Amman said, alone we are excellent, together we are brilliant. Thanks so much.
Thank you. Thank you. Thank you very much. Thank you very much, Tobias, for your great presentation. And yeah, I just want to inform that we are still gaining some minute for question and answers. So I think this is a great presentation where maybe we are expecting some reflections on it before we welcome the other presenters. If you have any comment or reflection, please raise your hand. I have Amman. Amman, go ahead, please.
Thank you so much, Tobias, for a very, very great presentation, and also very provocative in terms of the solution you showed from the Asian, the curve. Look, really impressive work. Can you comment on what they have done right and what can we learn from it as such for in the coming work, so to say?
Yeah, thanks a lot, Amman. And again, coming back to that, if we move back to the 1990s in Asia, especially in China, China was still a poor country at that time with bad nutrition, bad conditions for the large majority of the population, and with healthcare rather poor and not very well functional. So it's the combination of the whole building of a society with strengthened economy, less malnutrition, better education, when to seek healthcare and not, better water, better sanitation, and better healthcare with better diagnostics, with better treatment, better oxygen supply. And I think we as HoliCare can fill an important gap in looking at from the holistic approach, not just developing the diagnostics, but get the diagnostics out and teaching how to use this and look at this from a broader perspective. And that's what I see is an important difference with the HoliCare project compared to many others. But again, it's important. It's much better, and the curve is good. But still, in Asia, and it's also due to the big population, respiratory tract infections is still a big issue there. And for example, in India, China has improved a lot, but in India, especially there with the worsening air pollution, is getting so bad due to traffic and industry that many of the respiratory tract infections actually get much worse. So it's a combination there.
Great. We have also John Black, Kabuke. John Black?
Oh, yes, I was muted. Can you hear me?
Yes, we do. Please go ahead.
Yeah, great. So I'm also interested in this trend that is coming from the Asian side. And my question is about the role of environment and pollution, and this that we sort of tend to see as a big issue in the Asian countries, in China and India, and how that contributes to respiratory tract infections. And what's the evidence of that versus the situation in Africa? All the other improvements notwithstanding. Do you comment on that?
Yeah, thanks. It's a very important question. And if we look now, especially in India, but also in some of the bigger cities in China, the air is so bad that sometimes they even close the schools, that the children are not allowed to go to school because they know they get so much asthma exaggerations. So it's a big, big issue. And I believe if they had better air quality, the curve would look even better. But compared to most cities in sub-Saharan Africa, the air quality is much worse in Asia still. And then unfortunately, Africa is catching up with getting worse air quality, with increased traffic, with increased industrialization. So I really hope sub-Saharan Africa also can leapfrog there and don't need to go through all the issues that Asia and Europe have been through. And it's again, just look at the UK with the smog there 60, 70 years ago. So it has been an issue all over the world and also in the US. So it's a very important issue not to forget about. But it's not only infectious diseases, it's also asthma, it's chronic obstructive diseases and heart attacks, and the air quality is affecting many different illnesses.
Wow, that's great to hear. So we earlier on, we had a raised hand from someone called Richard Natuhera. Do you still want to talk, Richard?
No, my issue was resolved.
Okay, great. Thank you. I think we can just go ahead. Before we have a healthy break, I would like, if there's no other reflection or comment from the audience, I would like to welcome the third presenter, and that is Dr. Cheikh Fall. Can you hear us, Cheikh?
Yes, Jean-Claude, I can hear you.
Yeah, if you don't mind, please go ahead with the presentation. Cheikh is from IPD. He's going to take us through the context or perspective of RTIs in Senegal. So I think he has prepared something very important for us. Please go ahead, Cheikh. Cheikh, can you see the presentation now?
Not yet. Yes, I can see it.
Yeah, so the floor is yours, and you just let me know how to go through it. Yeah, thank you.
So if it's okay on your side, I can start.
Yes, please go ahead.
So thank you very much. It's a great pleasure for me to talk about the respiratory tract infection in Senegal. And this talk will be focused mostly on the management, the challenge, and perspective. So as you know, slide. Next. For this presentation, it will be structured following this outline. We will talk about the overview of respiratory tract infection, and thereafter we'll make the focus what is the situation in Senegal regarding the lower respiratory tract infection. And after, we will talk about the strategy for management regarding the lower respiratory tract infection. What are identified as challenges, and to finalize with perspective. Next. So as you know, and as said by Tobias, this is an overview of the respiratory tract infection. And as you know, respiratory tract infection are common. Is a common illness that affects the airway, including nose, throat, sinuses, and lungs. These include the upper respiratory part and lower respiratory tract. And we have identified 4 major clinical situations when we look at the upper respiratory tract infection. These include the rhinopharyngitis, acute otitis, acute sinusitis, and acute angina. And when we look at what is the sanitation situation regarding the lower respiratory tract infection, we mostly identify that usually we can find acute bronchitis, exacerbation of chronic obstructive pulmonary disease, and at the end, pneumonia. Next, please. regarding the acute respiratory tract infection, it can be considered as the leading cause of morbidity and mortality worldwide. And these situations are mostly found from the limit and middle income country. The most affected people are children under 5 years, of course, and also elderly. The WHO estimated this global burden as at least 20% of deaths from young children associated to acute respiratory tract infection. In sub-Saharan Africa and Southeast Asia, as said by Tobias, they have the most part of the disease and incidence regarding the acute respiratory tract infection. I would like to highlight what is the situation in West African country. A survey from 30 countries raised that the prevalence of the acute respiratory tract infection among young children are estimated at least at 60%. And you can see the distribution from the different countries where the study was performed. Next, please. Acute respiratory tract infection associated with multi-social and environmental risk factors. These include poverty, malnutrition, housing condition, but also indoor air pollution. These include parental smoking and also infants. Other risk factors identified include poor ventilation, overcrowding, industrialization, but also some social cultural reality, and also the availability of healthcare setting. And this pathology or this infection can be associated with different pathogens, including viruses, bacteria, but also fungi. It's also important to understanding what is the cause of this infection, but also to recognize symptoms in order to make appropriate treatment. Next, please. Overall, when we make the focus of the lower respiratory tract infection, as said by Tobias, the upper respiratory tract infection is also important, but usually mortality is less when compared to the situation of the lower respiratory tract infection. When we look at the situation in 2015, 2016, and 2009, at least 2 million, more than 2 million people are there from lower respiratory tract infection. That's why it is considered as the leading cause of death and disability among young children, but also the third leading cause of death in the world. As already talked by Tobias, the daily estimated life associated lower respiratory tract infection in 2019 is estimated associated at 40 worldwide, but also the second cause of death of dying among the young children. Next, please. This is a map regarding the incidence of rate of lower respiratory tract infection in 2019. When we look at this map, we can find that Africa have, but also South Asia has the highest incidence from of low respiratory tract infection. And the Guinea, which is located in West African country, and Chad and India has the higher incidence for this infection. And when we look at the incidence of death, we can find that Africa have the highest incidence of death associated to lower respiratory tract infection. These include the highest rate are retrieved from Central African Republic, Zimbabwe, and Guinea. All these three countries are located in Sub-Saharan Africa country. Next, please. This is a small comparison of what is the situation of global death in Sub-Saharan Africa. regarding the death and episode, we can find that mostly the global incidence is mostly frequent in sub-Saharan Africa when we compare it in different years, 2015, 2016, 2017, and 2009. And by making comparison about the death rate, we can find that Africa have a high incidence of death associated to lower respiratory tract infection. Next, please. Now we have to make the focus about the situation in Senegal, which is a West African nation with a young population, because most of the population have the median age is around 19, and children occupied at least half of the population, including children with under 5 years. When we look at the situation of low respiratory tract infection, we can say that few data are associated about this infection, and the available data are mostly from the pediatric setting. And in a study in 2015 estimated that the low respiratory tract infection was associated with high incidence of DILI, but also of death. And these parts are mostly retrieved from young children under 5 years, with a DILI estimated to 3.62, 10.9. And pneumonia and bronchopneumonia are mostly are responsible at least more than 18% of cause of admission for the low respiratory tract infection. In Senegal, we can find that more than 2,080 children die each year from pneumonia, and this is responsible about at least 12% of death in Senegal among the young children. Next, please. The strategy and or algorithm of diagnostic include when the healthcare professional receive patient, they make interrogation and in order to get history and on duration, but also the onset of symptoms. After this, physical exam can be done by looking, for example, the rhythm of respiration. And if necessary, they can make additional tests. These include chest X-ray examination, but also some laboratory tests with microbiological analysis, but also molecular diagnostic and also rapid diagnostic tests. Molecular diagnostic tests include culture isolation and identification of potential pathogen. And as you know, it's a little bit difficult to make culture and isolation from virus. That's why usually we are using molecular diagnosis tests to make diagnostic for viral infection. And in Senegal, a lot of laboratories are not equipped to make molecular diagnosis. That's why mostly we can, the etiology of these low respiratory tract infection are not well identified. Next, please. So as you know, etiology of acute respiratory tract infection remain unknown in half of the cases in Senegal, and the situation is due to probabilistic therapy applied usually. And these probabilistic therapy are mostly applied by using antibiotic, and this is frequent at the primary healthcare facility. And the finding of diagnostic are also related to inappropriate method used. As I said, culture and isolation are not available in most of the laboratory because they are not equipped to make this kind of diagnostic, but also molecular diagnostic. That's why usually we have not it's a little bit difficult to make a good diagnostic for this kind of infection. At the hospital level, usually they applied just only shift radiography to make diagnostic. And here we can found that some study make to evaluate the burden and identify pathogen associated to low respiratory tract infection. And the first one is a study realized in 2016-2017 among children from 3 different hospitals. And a result highlights the importance of viruses for the acute respiratory tract infection. Most of viruses identified are represented by adenoviruses, influenza, rhinoviruses, enteroviruses, but also RSV. Bacterial infection from this study highlights the importance of Streptococcus pneumonia, Moraxella catarrhalis, but also Haemophilus influenza. This was the most frequent pathogen retrieved from this study. The same situation was also observed from another study in 2017-2018 among children with high prevalence of bacteria and viruses. Next, please. When we look at the situation from adult, we can find that usually presumptive diagnosis are applied with and when we have when microbiology analysis is available, we can find that mostly bacterial infection are frequent with the isolation of Streptococcus pneumonia, Moraxella catarrhalis, but also Helicobacter, Escherichia coli. Another study realized in a cohort of HIV people highlights that low respiratory tract infection are frequent. Next, please. Regarding the treatment strategy applied in Senegal, usually patients are admitted at the hospital and the oxygen therapy are frequent. And beside it, they also use usually corticosteroid treatment and physiotherapy. And usually also healthcare professional applied empiric therapy before by using broad spectrum antibiotic before adjusting treatment after the feedback from lab result. And this adjusted treatment will be depend on the clinical feature of the patient, the type of pathology isolated, but also the severity of the disease. Next, please. For this in Senegal, as I said, we have a lot of challenges to access of diagnosis. These include poverty of population, level of education from the parent is also important, but also usually patients make a lot of time before going at the hospital to make consultation and treatment. Other barrier to access care is represented by the organization, the function of the healthcare setting. That's why usually access of basic medicine is a big challenge in Senegal, and also the quality of care. Next, please. Here is a representation of some strategy and made to improve to improve the situation regarding the acute respiratory tract infection. These include some policy developed by the Ministry of Health by establishing a training program on integrated management of childhood healthness. But also we have some strategy to improve the situation, the malnutrition situation regarding the most vulnerable population like the children. They have some strategy to make and implement microbiological surveillance strategy by using we have in Senegal an international a national surveillance network, and for this national surveillance network, Usually we collect some sample and make a microbiological analysis, including viral analysis. We have also some public awareness. It is recurrent by organizing some days for public awareness. The immunization coverage is improved mostly from young children, and we have also improved diagnostic and therapy platform. Mostly after the COVID pandemic, most of the platform are improved to make a good diagnostic for this. We are also to respect to compliance with the protocol for therapy management. Next, please. And regarding the perspective, we can say that it's important to strengthen antenatal care and maternal physical mental health, but also to upgrade the health professional capacity by making training and this kind of webinar participate of this strategy. It's also important to make to implement effective antibiotic therapy based essentially on the lab result, but also to improve and use innovative diagnostic toolkit. This is one of the objectives of the HoliCare project. As you know, we plan to develop some innovative diagnostic tools like multiplex lateral flow, but also point of care diagnostic platform in order to make access of diagnostic to everywhere. Next, please. I think I finished my presentation by this reference. If you would like to read this paper to better know about the situation, and I would like to thank all of you. Thank you very much.
Yeah, thank you very much. Please clap for him. Thank you, Amman, for online applause. It's really very exciting to hear this perspective from a country like Senegal. I don't know if there are any hands up, but I have just one reflection. You have talked about the social culture values as one of the factors that contribute to these infections. And I know it's not only in this domain. I know social culture values like in Africa or in Asia, they make people resist against these kind of technologies or these kind of new tools. So could you elaborate a little bit on some examples of like culture values that can hinder or that can cause these kind of infections, like in Senegal or any other example of Africa? Like examples, yeah.
Thank you very much. I think you have raised this point because, as you know, in Senegal and overall in Africa, it's a little bit difficult to push people to go to the hospital because they have some reality and some belief that can constitute as a barrier to access of the healthcare facility. And when we focus, for example, the vaccination, mostly people are not accepted to vaccinate children, and these make vulnerable this cohort of population for most of infection like acute respiratory tract infection. As you know, vaccines are available, but mostly parents do not accept to take vaccination for their children. And other kind of difficulty are also related by poverty, access of water to make washing hand is a simple action, but mostly we need to make awareness and also to sensibilize population to do this simple action.
Great. Thank you. Thank you. Do you have any other comments? I can see Puthmani. Please go ahead. Puthmani, you agree?
All right.
Yes, please. Yeah.
My question addresses, I think, one or two things from Cheikh's presentation, and is on what data sources inform the empirical treatment antibiotic therapy that's used in Senegal, and maybe it may as well be applicable to other sub-Saharan African countries, as to what data sources are being used to inform empirical antibiotic therapy, so as to ensure their effectiveness. I'm just curious to know.
So I do not feel well your question. If I well understood, you would like to know what is antibiotic therapy are usually used in Senegal to take care about the respiratory tract infection, right? Or no?
Yes. Is it local data, or is it global data that's used to inform the empirical antibiotic therapies that are used in Senegal? That was the question.
I think for your question, usually Senegal applies if I can say, the WHO recommendation to take care of the situation. But I think we need also to make a good study regarding the local epidemiology to adapt it. And it's because reality can be different between Senegal or overall Africa and other parts of the world. And mostly recommendations from WHO are global, and we need to apply our treatment regarding the epidemiological situation in Senegal. But as you know, mostly this kind of study is not frequent in Senegal and over in Africa. That's why it's a little bit difficult to respect and adapt treatment regarding the local situation.
Great. So we have Muna in the audience. Please go ahead, Muna.
Thank you, Jean-Claude, and thank you, Cheikh, for a great presentation. Just a quick question. You mentioned about HIV as an underlying infection, and I didn't understand what implication or complication that would have either for the treatment or the disease progress in the patient. If you could just mention something about that. Thank you.
Okay. For this study on the HIV people in this was an retrospective study realizing about what was the frequency of HIV people in relation with acute respiratory tract infection. And when we look at about this kind of population, they mentioned that we have at least low respiratory tract infection was frequent from this cohort of population, and the risk factor identified were mostly HIV, but also some practice like smoking, like alcohol also was identified as a risk factor to develop and having complication regarding the low respiratory tract infection from this cohort of population.
Okay, thank you, Cheikh. I think we have 1 more minute. I'm trying to scroll with my colleague here. There's no other raised hand so far. I think we can take like 5 minutes health break. Then we'll be back in 5 minutes. Then we continue with the next 2 presenters who will just take us through the Ugandan perspective. Thank you. See you like in 5 minutes. Hello, welcome back once again. I think we can continue our presentations. Now allow me to welcome Juliet from MUST, Mbarara University of Science and Technology. So Juliet, can you hear us, please?
Yes, I can hear you very well.
You're most welcome, and the floor is yours.
Thank you very much. So thanks a lot to the previous speakers and to you for the presentations made so far. It makes my work easier, and I have had to reduce some of the slides because many points are the same, really. But for all the listeners, you'll forgive me for repeating just a few. So this afternoon or evening, I'll be sharing assessment of acute lower respiratory tract infections, and I'll emphasize more on the perspective of Uganda, even if I'll keep mentioning a bit on the universal aspect. And I'll just dwell on 3 topics: description, definition of what LRTIs are, the risk factors, I'll have to repeat again and emphasize for Uganda, and then I will delve into what is being done to assess and diagnose lower respiratory tract infections. So we have seen this. We saw this definition from Tobias. We saw it again from Cheikh, but basically just for emphasis, intentionally, lower respiratory tract infections are infections that affect the airways below the level of the larynx. And in children per se, the most important are really bronchiolitis, bronchitis, and pneumonia, because they cause the biggest morbidity, but also deaths, especially pneumonia. And as alluded to by the previous speakers, the biggest percentage is caused by viruses, especially influenza virus, the parainfluenza virus, respiratory syncytial virus, adenovirus. And then, of course, there are bacteria, including strep pneumoniae and Staph aureus in the most severe cases, Haemophilus influenza. And then there are atypical organisms like chlamydia and Legionnaires that may also cause infection. Now, for Uganda, most of the epidemiology really is the same, but just to emphasize that 19% of admissions in major hospitals has been attributed to lower tract infections. And in children, 11% of deaths in children below 5 years are due to lower respiratory tract infections. So the risk factors, again, universally are really the same. Just to look at them briefly before we look at the ones in Uganda. Again, the age, as Tobias said, children below 5 years and the elderly. Anything that weakens the immunity, including HIV, as Cheikh said, or being chronically on steroids, or people who were on chemotherapy, and any other thing that will cause or that will depress the immune system. Severe malnutrition, and in this instance, undernutrition, which is quite prevalent in our country. It's important also note that a recent cold or flu can predispose to lower respiratory tract infections, because in the pathophysiology, the infection in most cases begins from the upper respiratory tract and then descends down. Recent surgery, because the airway is tampered with because of intubation or the patient being bedridden. And then those factors that irritate the airways really predispose to infection because they interfere with the mucous membrane. And as we know, the mucous membrane is the first line of defense against infection. So if these irritants such as smoke and other chemicals irritate, then the bacteria or more pathogenic organisms then invade, and this may result into a full-blown infection. So for Uganda per se, several studies have been done, but I just picked out 2, and most of them are in children. And there's this one by Nsimiyamana that really looked at data that was from the National Demographic and Health Survey. So it's really it's representative of the whole country, and it was among children below 5 years, where the risk factors associated included children below 1 year, children of teenage mothers, and children from of employed mothers, but especially on the farms. And these two categories, teenage mothers and mothers who are working, it is said that probably because the mothers are away, and then there's less care for the children, and therefore they're predisposed to infective organisms. And then lower risk was observed in children who were breastfed, and in children in whose homes the source of fuel was charcoal compared to cooking with firewood. And this is because charcoal lets out less smoke than if someone uses firewood in the villages. Now, the rainy season was also protective, and compared to the temperate areas, for us, the dust is an irritant and therefore predisposed to infection. And yet during the rain, there's less dust, and therefore children are more protected. The second study was carried out in a hospital in Western Uganda, and this one was on pneumonia only, where again, age of children below 6 months were more prone to pneumonia, living in a rural residence. And this again is because of probably the smoke and dust. And then incomplete immunization, which is really obvious. And then severe acute malnutrition, and babies who are not exclusively breastfed were also more prone to pneumonia. So for assessment per se, it's really, really important that this is carried out early and accurately, because if it's carried out early accurately, then it lays the ground for appropriate therapy. And if of course, again, if the infection is detected early, for infections that are prone to spread quickly, then effective infection control measures are put in place, and therefore others are not infected. And then again, if it's detected early, then the patient responding better to treatment is much easier, and therefore reducing the length of stay in hospitals. So assessment can be quite challenging, and we need to know this. And the challenges result from the fact that the way lower respiratory tract infections present may not differ so much sometimes from other conditions in children. For example, congestive cardiac failure, which presents with the same symptoms, and also obstructive airway diseases like asthma and others. In addition, the diagnostic tests and specimens sometimes are not that specific to lower respiratory tract infections compared to either other infections or upper respiratory tract. For that reason, it's very important that whoever is handling the patient or the healthcare workers understand the epidemiology, the clinical presentation, and the risk factors, because you have to use all these facts to suspect what type of organisms you may be dealing with to be able to institute proper treatment. The goal of assessment, several, but key among these is, of course, coming up the diagnosis that a child has a lower respiratory tract infections compared to another diagnosis, to determine the severity of the illness, because this will, as we shall be told soon, will affect how the child or patient is treated, and then to ascertain the etiology, and then you decide whether to give an antibiotic or not. So, like all conditions, assessment, clinical examination, and clinical history and examination are very important. And we have to remember that the symptoms, as we said, may also appear in other conditions. However, there are several, and they will vary from the mild to the moderate and to severe conditions. And in the mild, it's normally like the same to the upper respiratory tract infections, and they include things like a congested nose, a running nose, a sore throat, or a low-grade fever. While in moderate to severe, the child may have a much greater fever, temperatures ranging from 38.5 and above, and a serious cough. And the child will have difficult or fast breathing. There may be noisy breathing, such as wheezing or grunting sounds. And the child will be hypoxic because they're not getting enough oxygen through their blood. Chest pain is common, or sometimes if the child is older, may experience as tightness in the chest. And how severe or mild the disease is also maybe a proxy indicator of what organisms are causing this infection. This is not always true, but sometimes it's a proxy indicator. It is said that milder conditions may be caused mainly by viruses, but also sometimes strep pneumoniae may be a little bit milder compared to Staph aureus and Legionnaires and Haemophilus influenza type B. So for assessment, as Cheikh told us, there are several tests that can be done, or several diagnostic aids, including the chest X-ray, and each of these has their own challenges. But for chest X-ray, we would expect to see opacities, maybe interstitial or patchy. We may see consolidation, which also be patchy, or in different lobes, or or there may be a lung collapse or effusion. So there are several, and again, these features are not specific to lower respiratory tract infections, but they heighten the suspicion. And then we may do pulse oximetry, and this is really for management because it helps to determine severity if the oxygen is low, like below 92%. Then we may do also hematology and biochemistry. These are again just proxy indicators, whether it is, especially hematology, whether it is a bacterial infection or a viral infection, depending on the findings. And then microscopy, this one is mainly on respiratory specimen, but we shall see very soon the challenges of getting respiratory specimen. And then culture on blood or respiratory specimen. And then we may also do the specific antigen detection tests, which are the rapid diagnostic tests. This could be on respiratory specimen, on blood, or urine. And then, where it's possible, clinical biomarkers like procalcitonin and C-reactive protein are carried out, and these are used in an algorithm together with other, together with the clinical features, but also combined with X-ray and other laboratory tests to come up to decide which organism may be causing the infection. And then serological tests, really these ones target specific antibodies in blood, but again, they are not really specific to lower respiratory tract infections. And then molecular tests, as were intimated by Cheikh, including PCR and LAMP and so on. Now, these tests have challenges, which are exaggerated again in low countries, Uganda being among them. And for example, the chest X-ray, it is not obvious that you will find an X-ray in all the health facilities. You may find it in the bigger hospitals, but in health facilities in the rural areas where majority of patients go, the machine may not be available. Or if it's there, it may break down and it takes so long for the machine to be repaired. In addition, there may not be adequate technical manpower, or you may actually have a machine, but the hospital does not have people who know how to use this machine. And sometimes the images that are taken are of poor quality, and therefore making interpretation for anyone difficult after exposing a child to unnecessary radiation. Respiratory specimen, on the other hand, are quite delicate to handle. First of all, they may be contaminated, with organisms in the upper airway. And so then you have to use invasive methods to get, some of them, for example, bronchoalveolar lavage, or washouts, or endotracheal aspirates. Do you have a question, John Claude?
Yeah, 2 minutes just remaining. Thank you.
Okay. Yeah. So in the specimen is maybe invasive to get the specimen, but also you have to time, getting the specimen to be able to find the organisms, knowing in the background that many of the patients would have taken antibiotics before they present for the healthcare. Now, contextual issues in Uganda, we see that majority of children are seen by actually healthcare workers of a lower cadre. Like in this study by Jasper, where over 80% of children in primary health facilities are seen by healthcare workers of lower cadre who may not be able to examine properly or be able to interpret an X-ray or even know which specimen to order for. And then, as I said, diagnostic aids may not be readily available at lower facilities. If they are there, they may not be in good order to use. For this reason, Uganda, like many other low countries, adopted the integrated management of childhood illnesses, which is a strategy set out by WHO to help lower level healthcare workers to be able to assess and manage children easily. For example, for cough and cold, the health worker will have to examine the child and follow these steps, like if to be able to decide whether the child has a severe pneumonia or does not have pneumonia. The issues with the IMCI is that still the health worker has to know, how to count, has to have a watch to count, and has to know how to observe the child properly. Indeed, studies show that manual counting of respiratory rate is difficult, and sometimes it's overestimated, leading to overdiagnosis of pneumonia and therefore issuing antibiotics. On the other hand, because many of the health workers will not even have watches, a study in Uganda by Emily and others found that 40% of children who actually presented with respiratory tract infections, their respiratory rate was not counted at all. And for this reason, the HoliCare is embarking on finding better ways of supporting healthcare workers in areas like Uganda to manage children better. I thank you very much for listening to me.
Thank you. Thank you very much, Juliet, for your interesting presentation about the assessment of the RTIs. Because we have now Elias as the last presenter, and he's going to take us through the same context of Uganda, but mainly focusing on the treatment and prevention. So I think we can have the presentation from Elias, and then we have the overall Q&As from the two presenters at the same time. So Elias, can you hear us?
Yes, I can hear you. Let me try to share my screen. Okay, thank you very much. I am Elias Kumbakumba from Mbarara University of Science and Technology, Mbarara General Hospital. And as you said, I'll talk a little bit about treatment, follow-up, and prevention from our perspective here. I will do my best not to repeat what has already been mentioned, because there's a lot of overlap, and focus really on the areas that are very specific to Uganda in a way. I will again re-echo this, I guess, but just focus that in Uganda, the respiratory tract infections are not really different from Senegal and other places. But pneumonia forms the majority of the lower respiratory tract infections, as well as bronchiolitis. I have put tuberculosis in red because it's also a big infection in this region, but it's not, I'm not going to discuss it further. But yes, we see that, and sometimes children present acutely with tuberculosis. It's not typically always the long duration of illness. Sometimes we see children who have been unwell for 1 week, or whose story is about 1 week or so, and they actually have tuberculosis, but I'll focus on the others as well. COVID-19, of course, came in as well and caused several infections in children. Actually, here in Mbarara, we lost about, I think, 7 or so children. It wasn't as big in the pediatric as it was in the adult population, but yes, it's still important to mention, especially that we are also looking at it in the HoliCare work. Going straight away, there are children whom we see and know that they could actually be quite sick or have a higher risk of dying, and all will need admission, whether their respiratory infection is pneumonia or bronchiolitis or something else. So those with a rapid respiratory rate, and Juliet just mentioned that the respiratory rate is not always reliably counted, but where it is counted and it is high, or the tachypnea, the risk of the severity of illness is likely to be higher. Difficulty in breathing, including all the signs of difficulty breathing, really, that's a very important thing to look out for. It's actually most easily observable and one of the easiest seen signs, including chest volume drawing, nasal flaring, head nodding, and the others. Yeah, then yes, and then intermittent apnea and grunting. All the children, of course, who have another risk factor. I think someone talked a bit about HIV, co-infection, malnutrition. All those are more likely to raise concern. And then children are failing to feed. And children where the health worker judges that the family may not be able to safely observe and follow up the child. These children, we end up admitting them for additional assessment, treatment, and then some of these also get followed up beyond the admission period as well. Now, the management for the very sick children that I mentioned earlier, antibiotics are a very important aspect of their treatment, but not all of them will need antibiotics. Children with acute bronchiolitis, a lot of the time, of course, are erroneously treated with antibiotics because the distinction between bronchiolitis and severe pneumonia sometimes is not easy to make, especially in the settings where there isn't a lot of expertise. And so antibiotics end up being given to these children. But supportive care is very, very important, monitoring, and then, of course, other therapies. As again, Juliet said, we are using a lot, for most health facilities, the IMNCI approach for assessing, classifying, and treating, both important, are important, and there are guidelines that have really worked well for majority of the health facilities. In the advanced centers and hospitals, tertiary hospitals, they a bit more specific protocols that have been modified from the IMNCI or other hospital protocols. Right now, in Uganda, we are going through a process of reviewing protocols for the emergency treatment, triage and treatment of acutely ill children and newborns. What I put here, basic pediatric protocols, is a booklet that we are putting together from a previous review. A previous booklet. We are just reviewing it currently, and we will. It will be available. I think it will be signed off by the end of the month to be available for all health facilities that admit children to be able to use. And there are protocols on almost all common causes of childhood condition illness, with a good section on pneumonia and other respiratory illnesses. Actually, so it will be out. The 5th edition will be out by the end of the month. Yes, just a little more on antibiotic therapy. On antibiotic therapy, we have yes, you'll excuse me, my daughter seems to actually be getting respiratory tract infection, and she has come to me and is causing a little disruption in the presentation, but she will be sorted out. Let me get someone sorted out. Yes, antibiotic strategies. The NICE guidelines in 2008 kind of documented or described 3 strategies that could be used for treating respiratory infections. There are those in which no prescription is required, and those are mainly viral respiratory illnesses, where you know there's no need for for an antibiotic. There are situations which are a bit borderline, and you're not sure, the health worker is not sure whether to give an antibiotic right away, but may, and I think Tobias talked a bit about that, but may delay the prescription so that depending on the progress of the child, the patient, the family or the attendant comes back and picks a prescription or implements an already given prescription. And then there are those who will definitely need immediate antibiotic prescription. And those are the ones who are admitted and have evidence of a severe illness that requires an antibiotic, treatment. And antibiotic is part of that because oftentimes there is no easy distinction between a bacterial or a viral cause of the illness. In our setting, choosing the appropriate antibiotic is usually dependent on the national guidelines. For example, here for pneumonia, severe pneumonia, we treat, the guidelines recommend a penicillin, which is really benzyl penicillin or ampicillin in some cases, and gentamicin. That's the first line. And so everyone largely follows that to start a child who needs to be admitted and given antibiotics on treatment. But there are times, and there are some centers that have started misusing antibiotics really all over prescription, and I'll mention a paper. Yeah, so there's a little bit of, well, not really a little bit, but a lot of overuse of antibiotics, and I will just summarize one paper that was published recently about this. And because of the lack of confirmatory tests on which organism you are dealing with, and the lack of culture and sensitivity for most places, a lot of it is really is not specific enough to and sensitive enough to the organism that you're dealing with. So that's a major limitation, and the lack of another gold standard for diagnosing specific infections makes antibiotic prescription sometimes a bit too empiric all the time. The children who need antibiotics, as I mentioned earlier, will be those who are systemically very unwell, those who have symptoms and signs suggestive of serious illness or complications, and those who are at high risk of serious complications because they have pre-existing comorbidity, as I mentioned earlier. Those often get admitted and get given antibiotics. This study in Kasese of about 200, Kasese is a district in the western part of Uganda, about 150 kilometers from Mbarara. A group of our colleagues studied 225 children who were coming into a health center within the municipality of this town, and what they were doing was to see if rapid diagnostic tests could improve the prescription of antibiotics in these children. And using, they were able to do CRPs and procalcitonin for these children who had come in with a respiratory tract infection. And so they were doing tests, but letting the clinical teams provide the care. And so then do the CRPs, and so they found that if the clinical teams had used a cutoff of CRP of 40 milligrams per liter, or even been able to test for hypoxia, antibiotics could have been avoided in 33 out of 40 children who had been confirmed to have influenza, and another 157 or 85% of children who were influenza negative but still received antibiotics. Procalcitonin also gave them a similar situation. 88% of the children could have avoided antibiotics if they had a test, if we were able to test for procalcitonin. So rapid diagnostic tests or ability to investigate would definitely save antibiotics in this population. And this practice is really widespread. I think it's representative of what happens in most health facilities. The other part of care is really supportive. Oxygen therapy, suction, feeding, fluids, antibiotics, monitoring. All these are part of the care, but are not necessarily always available to all those who need them. For example, this was a study, this was a survey by the Ministry of Health in 2016 to look at supply oxygen availability at private and public health facilities in the country. And they surveyed 129 facilities and found that, yes, there was some capacity in 78% of them to provide oxygen, but those who had oxygen on their pediatric wards were only 47%. Yeah, so, and again, yes, there were lots of other challenges with pulse oximetry. Only 23% had oxygen and pulse oximetry. And then, yeah, and then only 15% had trained staff and oxygen and pulse oximetry combined. So there is a big gap in providing oxygen in our health facilities. And also there are lots of stockouts of fluids and other challenges within the health system. And then, of course, monitoring is not always, again, automatic. You place a child on antibiotics, you put a child on oxygen, and the next time the child is seen due to lack of staffing and others is maybe 6, even sometimes 12 hours later. So these are important, but there are still major challenges. I wanted to also highlight the fact that care is not only being given in the health facilities. Even in the communities, there are many things that people are doing in the community. This is a study from Kono, which is a district near Kampala in Uganda, where a survey was conducted in mothers of 278 children under 5 to ask them what they would do if their child had what they thought was a respiratory tract infection or pneumonia. And you can see the range of responses, a lot of things not necessarily very helpful, with ranging from traditional herbs, which is really, really very common, all forms of drinks that a child might take. A good, I think about 100 and a bit about 100 out of the 278 would take a child to a health worker, but others, or majority of them, would really try to do something before they take a child to the health worker, including things like giving raw eggs. Yes, many will get an over-the-counter painkiller food. So there are many things that people end up doing before they even go to health facility for these children with suspected pneumonia. Now, once a child is treated, our usual criteria really are across the country for discharging a child is one whose respiratory distress has resolved largely, no longer has a fever, and if you're able to measure the hypoxemia, oxygen saturations above 90, the child is able to feed well and able to take oral medicines, because we discharge children on medicines, all has completed the course of parenteral antibiotics and does not need additional parenteral antibiotics. But also important that the patient understands the signs of pneumonia and the risk factors, and also when to return, especially if the child gets worse. Unfortunately, in another study, we found if we told them to go and return, many would not actually return, because they would say, I have already been to health center or health facility, why should I go back? And in one study, we actually lost several children because the parents are not able to return, and the deaths were documented either at home or on the way to health facility. But there was significant delay among those who should have returned if the child got worse after discharge. So that's another area that's still difficult as well. Is follow-up necessary? When and why should we follow up these children? In Uganda, the majority of the follow-ups are really in the research settings, but also clinical follow-up clinics, where we say a child who has been treated and was severely ill, or had maybe an empyema or maybe had seizures associated with their pneumonia, should come back for follow-up. Those many, especially bigger hospitals, have set up such clinics. Majority of the others are not really doing enough follow-up for children who are recovering or have been treated for respiratory tract infections. In research, a lot of the time is to document outcomes, of course, of these children, or to monitor progress of the research objectives. Of course, when they come, they also get assessed for their clinical illness or their clinical progress as well. Many get assessed for their long-term complications, and with COVID, there's been a bit of thinking a bit about long COVID syndromes, And for children who have recovered from severe pneumonia, bronchiectasis, and any other complications may persist or may be picked up in follow-up. And interestingly, within the health system, the structure allows a referral or follow-up mechanism. The referral component works much more than the follow-up or feedback mechanism. So in the communities, there are people who call village health teams who are living within the villages of communities. So we refer children, we discharge children and ask them to be seen within the next 2 weeks by the village health team in their community. And then across the whole system until the specialized care at either specialized regional or national referral hospitals. And we know that also in a previous study, when you have a follow-up, a child who is seen within the next 2 weeks after discharge, their mortality, the risk for mortality actually significantly increases, sometimes by up to 50%. So it's a very important measure, but not well utilized in our systems really currently. This is one study just to demonstrate in the study setting what follow-up could look like. And we had a cohort of...
Yes, if we can have 2 minutes to summarize. Thank you.
Okay, let me summarize. But here, what I wanted to mention really is that if you follow up children very carefully over time, there are things that are important predictors of mortality after discharge. And out of these children, we were able to follow up 1,242 children, 390 of those had pneumonia, and a child who had a good oxygen saturation at admission was less likely to die after discharge, among the other post-discharge risk factors. This chart, as I wind up on prevention, this bar graph actually came out today from the Uganda Demographic and Health Survey of 2022 that was released today, this morning. And it kind of, I highlighted it because it talks a bit about immunization against diseases that could actually affect or cause lower respiratory tract infections. Our DPT here is coupled with Haemophilus influenza type B and hepatitis B. So Haemophilus influenza type B, when you see DPT1, DPT2, DPT3, it's coupled with Haemophilus influenza, which is a common cause of respiratory infections. And we see that there is a decline in completion of the 3 doses to 70% from a 96% at the first dose. The same thing happens with pneumococcal vaccine, whose 3rd dose completion is only 72%. And also the measles vaccine is at 83%. So yes, immunization is a good measure, but again, there are still challenges with access to immunization. The other things that we do is promoting infection prevention and control measures, and especially this happened with COVID and afterwards. And then there are children who are at risk of repeated respiratory infections, those who give antibiotic prophylaxis, especially cotrimoxazole or NV, penicillin V, for such, and those are used especially in clinic setups of sickle cell disease and others. And then a number of community measures really to improve sanitation, to improve hygiene, to improve welfare, and all that. I don't want to go without mentioning breastfeeding, where our completion rates of exclusive breastfeeding up to 6 months is still a challenge. And so many children are not really being breastfed exclusively for 6 months, but also they are being weaned much earlier than the recommended 18 to 24 months by WHO. And yet breastfeeding is well known to be very protective against these respiratory illnesses. And last, I list areas of research, including diagnostics, which is part of what HoliCare is doing, and optimizing treatment outcomes. And an area that we don't really fully know what could make things better. And then, of course, surveillance for organisms, so that we are targeting what exactly is happening in our communities. And maybe in the long term, we need to be looking a lot more at long-term effects of RTIs on survivors. There's a study that is ongoing, but we don't yet have results. But we hope we will understand what happens long after an episode of pneumonia or acute bronchiolitis or thereafter. I want to thank you very much for the opportunity and for the time and listening to me. Thank you.
Thank you. Thank you very much, Elias and Juliet, for taking us through the Ugandan perspective of RTIs treatment and assessments. Time is not on our side, of course, but we would welcome like 1 or 2 questions if there are some
Maybe this is me, Amman. A question for actually all three of you, including Cheikh. I'm just thinking about the hospital setting in terms of whether it's a smaller clinic or a big hospital. Can you comment on the level of, let's say, either diagnostics and treatment, whether that differs significantly, and if there is any strategy to tap the gap between within the same region between different settings?
Juliet, Elias, or Cheikh?
If I would rephrase it,
Yes, can you rephrase the question so that I pick it up?
I would rephrase it. For instance, if you have regional hospital setting, would that differ how you treat antibiotic resistance or how you treat patients compared to smaller clinics, or if they have a similar strategies depending? So I want to know whether there are discrepancies between accessibility to diagnostics, and then if there is, if you see basically stewardship programs, or how you would treat depending on what type of settings the patient would come to.
Yeah, thank you very much. Let me take that. Although there are national guidelines that should apply for the different levels of healthcare, there are a few factors that determine what the patient actually gets when they go to a health center 2, 3, or 4, or a hospital. One is the availability of the drugs. Then the Ministry of Health purchases drugs or avails drugs to health facilities depending on their level. So you may find that in a health center 3, they frequently run out of IV antibiotics, so that even a child with severe pneumonia may not actually access antibiotics appropriately, that are appropriate in that setting, and has to go to another a higher level. So that's one big factor: availability of the antibiotics or the right treatment at a specific level where the patient goes. So sometimes they will just give what they have instead of what is recommended, even when the standard is the same for the classification of the child's disease severity. The other factor is whether it is a public or private setting. In the public setting, a lot of the time there is aim to adhere to the to the treatment guidelines availed by the Ministry of Health, because they are the ones also who supply, the Ministry of Health also what supplies the drugs available. But in the private setting, we have seen a bit of a drive. I don't know if it's called an economically driven approach, where more or newer antibiotics are preferred, especially for those who can afford, than older, more traditional antibiotics. And so you find children receiving ceftriaxone, meropenem, and things like that, vancomycin, when actually in the right sense, a child should have just received benzyl penicillin and gentamicin. So that is another driver. And then, of course, in the communities, there are many there is access to antibiotics over the counter. So people can actually, children or parents can actually access amoxicillin right over the counter in their neighboring drug shop. And that affects the, of course, increases risk for resistance. Sometimes you just take a dose for a day or two and don't complete the full dose, and that delays real access to healthcare. And I think Dr. Juliet did a study in that area, and probably has something to add for the private and community-based facilities and care there. But that's in summary what really happens. And then in terms of diagnosis, there is limited capacity for diagnosis. Even in a regional referral hospital like ours, access to basic investigations is really challenging, and people have to pay for it. And that's a bit of another problem. And in others, it's not available. X-rays, full blood counts, acute phase reactants, all those are not available in most health facilities. So treatment is largely empiric, really. Thank you.
Great. Any other intervention from Cheikh or Juliet?
Yes, just to add something in addition, what the talk about the talk of Elias. I think in Senegal we have similar situation, and treatment procedure depend of the level of the hospital. And also what I would like to add is the availability of specialists also is different regarding the advancing level and also at the other end. And most of them are located in Dakar, in the capital, compared to the rest of the country. Thank you.
Yeah. Okay, great. Amman, are you satisfied?
Yes, sir. Thank you.
Thank you. I think as we wrap up, I would like to welcome my colleague Muna for some practical informations after this webinar. And then we will have the floor from Amman to close it. Thank you.
Thank you, Jean-Claude. And I know that we are really past the 2 hours, so I will be very short. First of all, I would just like to thank from us to the presenters who have really, that we're grateful for their valuable contributions. As Jean-Claude said, just some practical information. The webinar material, the video presentation, the slides, and additional material that is relevant to the topics that was presented today will be uploaded to the HoliCare Academy, which is now on the screen. So if you have registered, you will have access to it now. If you have not registered, please do so. If you have any issues, do not hesitate to contact us. I also want to inform that the next webinar session on the HoliCare Academy will take place early next year, and we will communicate the dates and the topics in due course time. In the meantime, please familiarize yourself with the platform and use the resources that will be available for you. A survey link, I think that's where the arrow now is pointing, yes, is now shared. This is on the announcement forum on the platform. We would really appreciate it if you could fill that in and help us improve the coming webinars. And so that's all the information from me. So I will hand back to Jean-Claude. Thank you.
Thank you, Mona. Thank you very much. Yeah, I think this link for the survey, we will also share it to your respective emails. And please do help us also to fill it. So now I hand over to Amman to officially close this webinar too. Thank you very much.
I think, Jean-Claude, you are too humble. Thank you. I would like to again thank Stockholm University for organizing this a very important series of webinars. Maybe to the participants, what I would like to ask you is to help us with spreading the word, because really this is about capacity building, and we want to really get engaged with people, with organizations, with others who have similar goals like we do. And again, I just want to reiterate that alone we are excellent, together we're brilliant. So that means let's help each other to spread out the words and try to make this into a global webinar events. With that said, I really thank you for organizing this. Looking forward for the next webinar. Thank you all.